Hello, everybody. My name is Jana Langhorn, and I'm the Senior Director of Marketing here at Synergistic, and I will be moderating today's webinar. Before we get started, I'd first like to welcome you and thank you for taking the time to join us. In just a minute, you'll hear from David and John, and they'll be discussing medical device and IoT device security challenges and best practices. But before we get started, I do want to go over a couple of housekeeping rules. So all attendees will be on mute throughout the presentation. However, you can use the chat window in the control panel to send any questions to us. And then in about 10 to 15 minutes before the hour, we'll stop and address all the questions sent through the chat box. And then I also just want to give everybody a heads up that we will send attendees a copy of the presentation and the recording later this week. With that, I would like to turn it over and welcome David Finn.
Thanks, Jana. Happy to be here, and I will echo Jana's thoughts as well. We know you are all very busy, and we appreciate your time today to join us. I am David Finn, and I'm the EVP of Strategic Innovation at Synergistic. As you can see, I've been doing this for a long time, have a few certifications. I am a recovering security and privacy officer, and under the heading of no good deed goes unpunished, I went from those roles to a CIO job and am fortunately having a successful recovery from that. Now, they say with age comes wisdom, and so I am the age part of this duo today, and I'd like to introduce the next slide, the wisdom part of our presentation. John Nye, who is our Senior Director of Cybersecurity Research and Communications. John is one of those guys who, if I didn't know he was one of the good guys, I would be very, very afraid of. John, I'm going to let you finish your introduction and then get things kicked off here.
Sounds good. Thank you, David. So as he said, my name is John Nye. I'm the Senior Director of Cybersecurity Research and Communications, which means I get to write about and talk about security and pen testing a lot. I started in the Army and have been working in InfoSec for more than 10 years now. In addition, just so you guys know, I've written a number of articles on information security, focusing on pen testing, hacking, trending threats, new vulnerabilities, IoT, biomed, phishing, and a bunch of other stuff. And most of those you can find here on our Insights portal, the Synergistic Insights portal. So we'll talk about what we're going to do today. We're going to talk about biomed and ICS and IoT. I'm going to kind of give you an overview. We'll talk about IoT devices in particular, ICS, which is something that a lot of healthcare needs to be thinking about, but doesn't as much. Biomed devices, which is a thing we're all scared of. And then the 4 questions, which is a really great tool you can use, and we'll go into details on that, and then we'll wrap it up for you. So we'll go and we'll talk about biomed, IoT, and ICS, which I like to call the axis of evil. That is what we see in our modern environment. So IoT is something that certainly affects all major verticals. Healthcare is definitely not alone with this pain point, but healthcare is a lot more deeply embedded in the ICS-based systems because hospitals generally have complex and large environmental controls that have to be controlled via ICS. That's an industrial control system. I'll go into a lot more detail on the section devoted to ICS, but unfortunately that's not the only category of endpoints. Also, that are of endpoints that are often referred to as IoT devices. So I want to make that clear right now. All of these are endpoints. They all have a network cable plugged into them. They can process data in some form, and so they are an endpoint, regardless of how we've classified them. So that makes healthcare's job even harder than the other counterparts. While these are not the only connected things that need to be foremost in our planning actions, it's important to know that the biomedical industry is plagued by many problems that are identical to ICS and generic IoT devices, but others are very specific, such as potential privacy and patient safety issues that you can run into with these devices. So one thing that we've all in InfoSec dealt with constantly is this CIS critical controls. We've all heard of their 20 critical controls, and they're all very important. But just the first 6, which is also known as the basic CIS controls, is a great place to start, just to help you if you can get a handle on these 6 areas, especially in regards to your IoT, biomed, and ICS, then you could be significantly ahead and more mature than the majority of your peers. So just looking at the very first control, which has been the #1 control for over a decade now from CIS, which is inventory of and control of hardware assets. And as we go through these IoT types of devices, that is without a doubt the biggest problem we run into, is so many of these devices are on the network and are unknown to the security team, etc. Continuous vulnerability management is almost non-existent with IoT, biomed, and ICS systems. Secure configuration for hardware and software. Again, another big problem we run into: consistent default credentials and insecure protocols running on these, just as an example. Inventory of software assets. This does come into play. An ICS system generally will run with a plethora of hardware devices called PLCs or primary logic controllers that are run by a central software. That software needs to be understood and inventoried. Also, control and use of administrative privileges. These devices often have default administrative accounts set up on them. That becomes a very quick way in for the bad guys or the good guys when we're doing an assessment. And then maintenance and monitoring and analysis. So many of these devices don't even feed into SIM logs or your SOC, whatever you have running that monitors. So these are just 6 of the 20 controls, but these 6 will help you a long ways. So under attack, computers are everywhere. What took an entire room 20 years ago, we now fit into this, you see the tiny picture on here of that's the smallest version of the Raspberry Pi, which is as powerful, if not more powerful, than that giant piano-sized computer they're loading into that building. We see the same. Our phones are more powerful than computers were. We have TVs that have computers built into them. Everything is becoming, with big square quotes around it, smart. So IT grew quickly. What took 25 years, or what took a whole room 25 years ago, can be held in 2 fingers, meaning more computing power is now available for significantly less money. This, coupled with the cheapest cost of storage per gigabyte in history, which is where we're sitting right now, with the cost expected to plummet to less than 8 cents in the next year per gigabyte. So they're expecting more data to be kept longer, more systems capable of computing, processing, generating, and ultimately stealing or leaking that data. So we have to do something to lock these down. So healthcare organizations keep next slide, please. Healthcare organizations keep biomedical devices in service longer than any other endpoint, sometimes 15 years or longer. Using these devices means that CISOs need to secure legacy operating systems. This includes Windows 95, 98, or XP. And to complicate the issue, device manufacturers are reluctant to disclose what's even installed on there, so the bill of materials. So security team might not even know what operating systems it's running, let alone what they need to protect, or the inherent vulnerabilities that are in each device. And then to further complicate matters, patch management and application third-party security controls such as antivirus are likely not even possible for the majority of these biomedical devices. Security teams are also hampered because the biomedical devices cannot be scanned with traditional IT systems. It'll often cause issues. Devices may potentially not be able to be turned on or booted except when they're physically connected to a patient. So active vulnerability scans becomes either impossible or creates a real risk of causing the device to malfunction or cause patient harm while it's connected. So that's just a brief overview, but we'll go into a lot more detail. I'll let David talk about IoT devices.
Thanks. And next slide, Jana. IoT, just a few years ago, was a term that most people didn't even recognize. And I believe Cisco was the first Silicon Valley company that actually set up an IoT division, followed by my employer at the time, Symantec. And IoT today is not this highly kind of sexy thing. It is kind of a catch-all term for anything that connects to a device to a network and consequently probably the internet that isn't a traditional endpoint like a laptop, a desktop, or a server. And these range from kids' toys to your Alexa to thermostats to refrigerators. And regardless of their functionality or whatever it's designed to do, most of these devices, because they have enough of an operating system to connect and send information to and from the internet, they are vulnerable to attack. In our hospital and healthcare settings, IoT devices frequently are not vetted or approved by a central IT department because they come in other ways. They're not necessarily an IT purchase. IT probably doesn't buy the televisions for the patient rooms, but as John mentioned, many of these television sets are now computers. You put them on the network, and obviously if you can see the internet from that device, the internet can see you, and it becomes a vector of attack. And the other issue is because they're coming through unofficial channels and because they are so ubiquitous, they're in things we don't even think of. It's consumer IT. And one of the issues around IoT devices is that they are full of open code software, and it pervades those operating systems. And that is going to be a growing issue because the open source developers actually lower assembly costs. They keep these things cheap, and they can innovate very quickly on them. In fact, without the open source innovation, most of the gadgets and cloud platforms and networks and phone systems we have would shut down today. And this means that security vulnerability in a piece of open source code is likely to exist across a multitude of applications and platforms. So these open source devices become new vulnerabilities no matter how they're connected. Next slide. And so the risk then, whether it's officially acquired IoT or it walks into the hospital with a patient or a physician or some employee, we've now introduced all these vulnerabilities, and that number actually from 2017 tripled from 2016 of known vulnerabilities. So we're going to see more and more of these issues. And based on the vulnerabilities in the first 6 months of 2018, it looks like we're going to have another record-setting year here. So IoT devices are cheap, as I've mentioned. They're frequently not owned by the organization, and each one represents its own set of risks. Whether, some of the common issues, even if IT is acquiring it, we see default configurations, we see hard-coded passwords, we see insecure protocols. They're, if they can be patched, they're difficult to patch, but they may not even be patchable. And because they come in through so many different ways, even if central IT is acquiring it, they may not know that there's IoT devices or IoT connectivity in those devices, like we frequently see in biomedical equipment. And if it comes in unofficially, it's unknown and unauthorized, so it's a risk right there. But again, we have the same default settings. We have poor password management, if you can even set the password. And because it's a lot of the stuff coming in unofficially is consumer grade, like the smart speakers, Alexa or Amazon Echoes, we're actually seeing those being deployed in offices and patient rooms. It's consumer grade, and they are not inherently secure. So next slide. So how do we get a handle on it? What you'll see here is getting a handle on the IoT is not that much different than what we had to do many years ago with servers and laptops and PCs. You have to start with a policy, and it has to be a clear, concise policy about what's allowed. And because IoT is so ubiquitous, you're probably not going to be able to talk specifically about things or devices. You're going to have to write a policy that talks about things that connect, no matter what they are. User education, this is going to be key around IoT, because everyone knew when they were sitting at a desktop that they were using a computer. Today, they may not know that the teddy bear they bought for their child is actually transmitting and storing their conversations on the cloud somewhere. So we have to be very careful about user education, and we have to explain the why when we educate users. It can't just be you can't do this, you can't connect this way. We have to explain why and what the risks are and what the issues are, not only to the organization, but to those individuals as well. Like anything, it's got to have a start date, an effective date, so you have to set a deadline, and it can't roll on forever. It has to be something reasonable, a 60, a 90-day date where you start enforcement. And enforcement starts with this physical and logical search. You have to go hunt down these devices. You may use a tool to find the ones on the network, but a lot of these devices, even medical devices, come and go from the network and may be off the network for extended periods. So at some point, you're going to have to do the walk around. And then comes the ugly part, removing the unknown devices. And in the old days, in the mainframes, when we had reports that no one knew who they went to, we just stopped printing them and see who hollered. And that's kind of the approach you're going to have to take here. If you don't know in IT or security what a device is doing, you're going to have to disconnect it and see who hollers, and that's probably the best way to find out what it's doing. Next, you're going to have to work with the owners to secure and approve those devices, assuming they actually do need it for business. I once had a user who worked in the basement and had stuck a network camera on the outside, so they had a monitor in their office so they could see. It was a virtual window. We found the camera and took it down, and we suggested a painting to them. But people get very creative about these devices, and they're so easy to use that you have to figure out if it's for work or not. Inventory, John talked about that, and this is the hard part. But you have to find all the devices that are coming in, whether it's a network card or however they're connecting wirelessly to your internal wireless network. You've got to hunt down those devices and be able to understand what they're doing in order to secure them properly. And the last piece, like so much in our security world, is really about educating. We say enforce, educate, enforce. I would say educate, 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 enforce, and then go back and do more education and enforcement. But you cannot overtrain your staff, particularly in this area where we take these devices and this connectivity so for granted. Next slide. I was very excited to see this slide. I love to talk about Buzz Lightyear and Woody, and here you see an actual photo of Buzz explaining to Woody where these devices are, and they go to infinity and beyond. We don't even know all the places that these devices are showing up, and nowadays our smartphones very frequently work as IoT devices with apps and other additions to those devices. So these are the things you need to look at, the things you need to be aware of, but basic IoT is literally everywhere. And I'm going to hand it back to John for another ugly discussion.
Yes, we'll talk about industrial control systems. So we can go to the first slide there. So ICS or industrial control systems, they're like IoT, they affect almost all industries. Essentially anything that requires HVAC beyond what you'd install in a home requires at least some aspect of an ICS control to keep that HVAC and other industrial grade systems running smoothly. So in retail and banking and all those industries, ICS is a relatively small corner of their industry, as they're basically just running the air conditioning, the HVAC, but it's still been the cause of many major breaches. Most famous, well-known example being the giant Target breach. They were hit with major breach we all heard about, many of us were affected with, during which millions of credit card numbers were stolen, and the attackers gained entry to their relatively secure intranet via their ICS system, their HVAC system, which was being managed by a third party. And healthcare is significantly more deeply entrenched in the world of ICS than all but maybe the world of crucial utilities like power and water. Hospitals have large and complex HVAC systems that not only control the individual temperatures in parts of the hospital, but they are also responsible for maintaining optimal humidity and keeping rooms either positively or negatively pressurized to allow for sterile environments, and keeping diseases within a certain area. These complex and connected systems are typically only part of the ICS infrastructure that the average hospital maintains. So in addition, there'll be ICS set up to maintain and condition the electricity, as well as backup generators that are turned on as needed. There's also several other systems we find in hospitals that rely on ICS, and the PLCs, or primary logic controllers, that the ICS controls. For example, many hospitals have gas oxygen delivery systems throughout the building. Also, most security and access control systems run via ICS. And then we've not even talked about how PLCs control the flow of water. So all of those things are affected by that. Losing control of any one of those systems would be catastrophic, certainly trigger incident response in the least, if not affect the provider's ability to provide care, and even possibly risk to the health and life of patients and even employees if there's an infectious disease area that is affected by this. So ICS is something that healthcare absolutely needs to be concerned about. Let's go ahead and switch to the next slide. So why is it so risky? The first word in ICS is industrial. So industrial systems, by tradition, are designed to last for a decade. So if somebody builds a new power plant, they don't want it to have to be rebuilt in 4 years. That makes logical sense. However, now that we're moving these devices to more and more IT based, is where we start running into a problem, because an IT life cycle is 4 years. And there's a reason for that. You don't want a 10-year-old operating system running on your network. Again, these systems are designed to be incredibly simple and very robust. So they're very rarely patched. The primary logic controllers, which are essentially dumb, which means they just do what they're told. They receive directions from the central ICS. And these can be valves, switches, sensors, any sort of device that helps to control the flow. And ICS in general run using insecure and old protocols. So ICS in general runs off of what they consider to be obscure protocols, but rarely are they encrypted. So we can go to the next slide, please. The industrial controls in your facility are likely fragmented and likely have never been looked at for security of these connected devices. The first and most important step is to look at what's there. Find out what ICS type devices that run at the facilities that your organizations are responsible for. Are these systems connected directly to the intranet? Are they connected to your internet? Those are huge. Or worse yet, are any of them accessible from the internet? And you would be shocked how often we're able to get to these devices from the internet. In most cases, the best possible fix, or at least in the near term, is to just remove these devices from the internet and intranet access. Put them on their own completely segmented, separate network, or at least on a completely segmented VLAN. that cannot be accessed or access any other especially critical systems. So segment, isolate, secure. And as we wrap it up, so these are unseen devices. We rarely see these. In fact, walking through most hospitals, I frequently see these sort of grayish panels with a few blinking LEDs. Those are part of your ICS system. Nobody thinks about them. Nobody looks at them. So what are yours doing? Have you thought about these? Has your IT department looked at them? ICS is core to how most hospitals are able to provide care. So if we don't begin to look at these are going to be the first way that bad guys can stop us from providing care. And then finally, in many cases, ICS can be have direct or severe impact in your ability to provide care. So now let's talk about biomed.
Thanks, John. This is a topic near and dear to my heart. As a CIO in the early 2000s, I was given responsibility for biomedical engineering, which I knew nothing about and really didn't have to. And then some of our clinical engineers decided, and our clinicians, because they are a part of this, decided to connect some of these devices to the network to begin feeding into some of our other clinical systems. And my director of clinical engineering decided I needed an education. He was exactly right. And I started spending time with the CE team out in the field, learning what they do. I learned more about water than I ever hoped in our dialysis section. And I saw a biomed tech actually take a jump drive out of his white coat after servicing a dialysis machine and stick a jump drive into this device, which he was about to go connect to a patient. And because I came from a security background, it was horrifying to me because I hadn't seen him scan it. I hadn't seen him check the device. And he looked at me and said, "Oh, I know you're worried it's got something on it." He said, "But it came from the device maker, so it's perfectly fine." And I said, it may be, but let's check before it. I had one of our analysts come down. We scanned it. It was fine. They did the firmware upgrade on the dialysis machine and took it out. But it made me keenly aware of the differences between IT and clinical engineering. And in hindsight, it pointed me to the integration of clinical engineering and IT that we're all going to be faced with. So I won't go into all the history, but traditionally, clinical engineering was really based and focused on maintenance. They took care of very specific devices that didn't connect to a network. They probably connected to a patient, and they made sure they were working and functioning and did what they were supposed to. But today, clinical engineering is extremely sophisticated. The technologies are highly advanced, and the technology management has to include not only strategy around those devices, but quality and safety for the patient. Big difference from traditional information technology. They're responsible for training and hardware and software support. Someone has to teach nurses and other clinicians how to use these devices. They have a regulatory and compliance burden with the FDA and other rules. They are doing vendor management because no one gets all their medical devices from a single source. They've got asset management, installation, and integration. They are doing information technology because healthcare is about information now. And on the other hand, IT was really focused on the business side of healthcare. When I started, we were looking at accounting and billing systems. We tracked AP and supply chain and payroll, but we weren't as involved in patient care as we were once the advent of the EMR and the rollout. And now today, information technology in a hospital or a healthcare setting is about clinical workflows and clinical decision support and quality of care and outcomes measures in this world of value-based care. Next slide. And we see this commonality that I should have seen many years ago, but it's coming into sharper focus now. We've got integrated medical systems that are capturing and storing and allow the retrieval of physiological data and images, not just traditional medical images like X-rays and MRIs. We permit remote viewing of stored data, which is new on a new level. You used to be able to look at that stuff anywhere in the hospital. Now physicians, for consults or for outside review, are viewing these things around the globe. And then information is being charted into the EMR, into the medical record. And they're ingesting personal data from wearables and remote monitors. I was recently at a customer where they were working with Fitbit to actually do direct data ingestion from a patient's Fitbit, a cardiac patient, into the EMR. We're seeing more and more of this convergence. And these are some of the examples that were older, but they are growing every day. Just physiological monitoring, telemetry, cardiac cath lab, and diagnostic cardia systems. I mentioned the Fitbits, and even alarms from systems. Some of these wearable systems are being read in, as well as the traditional PAC systems, lab, and pharmacy systems. Next slide. And if I haven't convinced you yet, we're seeing more drivers related to this clinical engineering and IT convergence. I think everyone has seen the integrating healthcare enterprise at HIMSS. This is now a standalone venture. IHE, we're going to see more and more of that. We live in a value-based age as we shift from fee for service to fee for value. So we're going to see more patient safety and more quality outcomes management. And that is about measurements and metrics and collecting data. And obviously we're seeing more telemedicine now that the federal government has accepted that, the AMA is on board, there's going to be a reimbursement model. We're going to see more and more telemedicine. So these devices are not just traditional, physiological monitors anymore. They're going to be tele something that allow remote monitoring and access to that device, to that data from the EMR or from a remote view by a physician or other caregiver. We're seeing obviously more RFID, more DICOM imaging around some of these things. Bluetooth is everywhere, and Wi-Fi is ubiquitous too, which gets back to the whole IoT problem and where you connect from there. We're talking about increased government and industry focus, not only the FDA, but the MDS2 documents, other initiatives. We're seeing legislation in the Senate and Congress pending around medical device regulation and safety. Just yesterday, both Becton Dickinson and Philips announced new vulnerabilities, and I applaud them for being transparent and announcing those findings when they discover them. So we're not just waiting for a disaster to happen. We know there's an issue and we know it needs to be addressed. But again, more work for IT, for security, for clinical engineering, driving this convergence. And last but not least, since this is patient data in most cases, we've got information security, integrity, availability, and confidentiality on devices and in locations that we haven't even thought of yet. And it's, yes, it's about HIPAA. Yes, it's about cybersecurity. Yes, it's about disruption, whether it's ransomware or a denial of service attack. But ultimately, security in the case of these medical devices is about patient safety and the quality of care and the quality of the outcomes. Next slide. You can go ahead and build this out, Jana. When I was at Symantec, I worked with a brilliant clinical engineer and security expert who had a background in clinical engineering. I borrowed a couple of his slides to kind of paint the image, but we can bundle all these issues into an exploitation bucket, And all those exploits really direct us to the risk and impact around medical devices and the threat scenarios. Obviously, we have the traditional ones. There's issues around data breach and brand reputation and revenue and cost. But medical devices impact patient safety and business continuity in ways that no other device really can. They are often patient touching, being used for diagnostic or therapeutic treatments. And the other key box here is labeled business continuity, but that really is clinical operations. If your cardiac cath lab is shut down with ransomware, you are passing on a lot of patients. The devices are not availability. You may have network performance issues if certain devices are taken over and being used for crypto mining. And they're the kinds of devices that typically don't hit the top of mind for an IT security person. Next slide. And one of the things I learned from my clinical engineer security friend was we need to take a best practice approach. There's a little more build out here. And that includes things like asset management and procurement, which IT is usually pretty good at. One more box. But the security risk analysis and risk mitigation and risk management, as well as incident analysis and lifecycle management of the device and the data, kind of fall outside of traditional IT responsibility around medical devices. So while they are doing a pretty good job at asset management and procurement, and they're looking at the FDA requirements and the MDS2 documents, they may not be looking at it from a security perspective. And this is the part we need to build into that biomedical practice. Next slide. And what I've discovered is today we really have two approaches within healthcare. We have the perspective that says a biomedical device is just an endpoint on the network, and that is correct. It is an endpoint on the network, and you have to take a security approach. You have to scan it. You have to identify vulnerabilities. You have to look at fixes, mitigation, and you have to keep doing that because it is a device on the network that talks to other devices and can spread things, some things you want it to share and some things you don't want it to share. So there's that perspective, but biomedical devices are unique devices in the perspective that they really impact directly patient care and patient safety issues. So you have to be able to group and classify the devices. You have to prioritize the devices for remediation based on the patient risk and clinical operations. A blood pressure cuff, for instance, that gets held for ransom and goes down is probably not that big a deal. You can pull an old blood pressure cuff and still get that. You're going to have to write it down somewhere instead of directly feed that data into your EMR. But if it's a medical device in the OR, like an anesthesia machine, that's going to be a higher priority. That you can't protect after the fact. It's got to be safe going into the procedure. And then you have to build security remediation and clinical engineering, preventive maintenance together. And that isn't a rinse and repeat. That has to be continuous. Next slide. And so you really have to take the whole biomedical device life cycle management and build security into that from the beginning. You start with your device risk management and determine what devices will come on and how they'll connect and what are minimum security requirements and whether the vendor has to do those patches or allow patches. And then you have pre-device acquisition procedures, and this includes looking at the MDS2 documents. Frequently, we go into an organization and we ask which devices contain or store PHI. And usually, organizations can't tell you which devices are storing PHI. But we've seen bedside sonograms that have up to 800 data on up to 800 patients. You want to go through a vendor selection and build security that in. And when you're doing your device implementation, you want to look at not only the implementation architecture, but the network implementation architecture. John mentioned segmentation and VLANs. This has to be part of how we deploy these medical devices now. Because they are an endpoint on the network, you may want to integrate them with your SIM or your SOC, or if you have a managed service provider, provide that data back to your managed security service provider. The technical training around these devices isn't just as simple as using the devices now. It has to include security training and things to look for and things not to do. I have actually seen an MRI tech using the MRI interface to get their email on the medical device. Not a good practice. It's part of training as well as setting up rules for those devices. And you want to go through your entire life cycle. And as you're building out your incident response plans for bigger cyber incidents, you want to be able to address the biomedical devices in terms of the bigger IR plan. And then as you retire these devices at the end of life, you want to look at the device itself, the data it stores, and how those hard drives are retired, where that data goes, and if it's being properly destroyed as part of that practice. And we're to the 4 questions. This is a set of questions that we developed internally to help guide organizations to better understand and address their issues around medical devices. Everyone has dealt with a could not locate list. I will never forget the first time I was working in a hospital and heard a page for a bed and was terribly confused that someone was actually paging a bed. But it was a bed that had gone off inventory. It had been relocated and they couldn't find it, could not locate. And so someone thought it would be clever to page the bed and that someone somewhere in the hospital would have a bed that they knew they took and shouldn't have, or something like that. So these are kind of the 4 questions. And since I've got the first one, I will say that this really addresses inventory controls. It goes right back to your NIST CSF and a management control. And if you can't actively track these devices, you really are not doing asset management the way it needs to be done. So this is a good question. This is not a technical question. You can share this with your executives, with your biomedical team. And if you've got 25 devices on your could not locate list, it would indicate that you have a problem right there. Second question. And this is really the point I was making earlier is, does that device have protected health information or any kind of confidential information you don't want floating around? And it addresses the risk management control, identification. NIST, if you're looking at NIST, it's identification, risk assessment 4. If an organization can't identify which devices have the highest impact to the organization, the highest business impact to the organization, then it hasn't completed a full risk assessment. John, you want to hit 3 and 4?
Sure. Let's go do the next one. So of the missing devices that have PHI, how many of those instances have either been reported to the OCR as a breach of PHI? We tend to find none is the answer to this. One thing I want to point out, these 4 questions are a tool for you. So you can take these 4 questions. If you can figure out the answers to these are what's going to get your executive's attention. These are what's going to get you the resources you need. Let's go ahead and look at question 4. And then, so for all the devices that are left, which of those have technical vulnerabilities that cannot be remediated? And there's another instance where most of the time, the answer is I have no idea. And even just knowing that you have no idea is huge. And you can bring that to your executives. So the biggest takeaway from these 4 questions is these are your homework. These are what you could take home and work on and actually use to begin to make an impact on the IoT, biomed, and ICS in your organization. So so like I said, those 4 questions are going to help. Again, they're not perfect. They're not going to get you 100% of the way there, but they're definitely going to be a good start. And making an effort is the first step. Centralized management is key. We know a lot of healthcare organizations don't have very big IT staffs or IS staffs, but even with limited resources, you can still make progress. Just answering these 4 questions, bringing it up to the board, making it known that this is an issue. It might be a slow process, but beginning is critical. And don't be discouraged by the sheer size of this. It is a huge problem that is affecting all of the industries in the world, not just healthcare. And you are not alone in having to deal with this. So don't get discouraged. But if we don't act, we're never going to get it. It's never going to get any better. That's the most important part.
All right. Thank you so much to both of you, David and John. From here, let's go into the Q&As. So first, I want to be sure that everybody knows that we will be sending out the slides along with a copy of the presentation later this week. But as far as questions go, John, the first one I have for you, is there any tool or tools that you can suggest that will help with inventory?
So we don't typically recommend a specific tool, but I will give a caveat. So I've seen in the last 10 years, I've probably seen 40 or 50 different tools that people have tried to implement. They've all been promised by the vendors up and down, left and right, that it's going to find every device in their network. I'm going to tell you right now, it won't. So there's not a technical solution that's going to fix it all. But there absolutely is tools out there that these inventory tools that are available, and there is a plethora of them on the market, that will help you to at least identify a portion of the devices. I think about 90% is the closest I've ever seen one get, though. They're still going to require some manual walking around, going room to room. So, next question.
And then I know you already touched on this a little bit, but I'll go ahead and ask it again. So with the concern over costs at hospitals, how do we convince the C-suite that we need to spend more money for protection of these medical devices?
I really think, like I was saying, those 4 questions is going to be a huge factor. Showing them how many devices you couldn't locate, which of those devices are containing PHI, that is very actionable intelligence. That is going to open their eyes and at the very least get their attention to move things forward. But really just educating them and letting everyone understand just how serious this is going to be our biggest help, I think.
Okay, thank you. And then I just want to remind everybody that's still on the line, if you have any questions, feel free to send them through the chat window. The next question I got is kind of a similar one that we've already touched on too. What type of resources could see these devices and allow them to be centrally managed?
Yeah, so again, we come back to tools. I know David mentioned Simile is one, and there's a few we have worked with. There's a handful of tools that are developed specifically to help with biomed and or IoT devices. So they're designed to do scanning that is not harmful or could cause those devices to crash. It's pretty easy frequently with those devices, but the simple scan could cause it to fall off the network. So they're designed to work with these sort of fragile devices. They're also so there is some out there, and a Simile is one that we've looked at.
Okay, and then one of the questions, I'm not sure I understand it. Is there a good DB, I assume database, available to ID devices, say based on MAC, so we can at least classify an inventory system?
So that's really a good question. There is inventories, databases out there that are going to help you identify, the specific NICs, for example, because they're going to have a certain MAC that are often used in, maybe GE devices. You're probably still going to end up having to go put hands on those devices. So those are going to help you to identify, hey, this is not just a Dell laptop, but it's probably not going to tell you this is, X-ray machine model number 4935 by GE, if that makes sense. So there is resources out there that will help you to scan and point you in the right direction at the very least. And you can absolutely send us an email, and we can give you recommendations for what some of those tools are. Some of them are open source, and some of them are, things you have to go and purchase an app.
Okay, some great questions that we're getting. Another one I have, it's more so a comment than a question, and that was when talking about ICS. Don't forget that elevators and escalators are included in that. So is there any thoughts that you have on that, John?
No, I'm glad you brought those up, though. Every time I go into a hospital, I think of another system that is being run by PLCs in an ICS. So you're absolutely right. Escalators and elevators is another one. Also, the automatic doors would probably be just the doors that open up for people, the handicapped entrances. There's a lot of things that are controlled by ICS, and I think that as we go digging into this, we're going to find more and more things that we never thought of, like that gas and oxygen delivery system is something I've only recently thought of. Another one in some older hospitals we see are the pneumatic tube systems they use to pass samples and notes around. So there's a plethora of things that are ICS controlled. Also, the narco cabinets, the narcotics cabinets, are going to be controlled by a PLC. That's going to unlock it. So, yep, you're right. There's a lot of stuff to think about.
Okay. And then one more question I have for you is, do you have a good source or resource best practice templates for policies and procedures around devices?
There are no limit to them out there, but I generally send people to CIS. I think that the Center for Internet Security has really, really well made templates that you can use. But again, feel free to reach out to us and we can point you towards some of those resources more specifically. But I almost always find what I'm looking for on CIS when I'm looking for a sample template.
Okay. And then any last questions? I don't see any more. Do you want to remind everybody that, again, we'll send out the slides and a recording of the webinar later this week. And after the webinar today, you'll receive a short survey, and we would greatly appreciate if you could take a few minutes to share your feedback with us and let us know if there's any other topics you'd like to see in the future. So if there aren't any other questions at this time, oh wait, I think we got one more. I'm looking for John's email address. We can send that out. That will be included to all attendees after the webinar.
Yeah. It should also be on the slide. It's just john.nye at Synergistic, and you'll be able to reach me.
Yes, and feel free to reach out with any questions that didn't get answered. And again, we thank you so much for your time today and are glad that you were able to join us and hope that you found this very educational and informative. With that, I'll give you back a few more minutes of your day. Thank you, everybody.
Thank you, everyone.
Thanks, John.
No problem. Thank you.